Let me request Dr. Sivakumar to give a talk on assessment of another important set of patients, that is in-stent restenosis. So you start, Dr. Sivakumar.
Yes, sir. Respected Chair, Dr. Kaul sir, and my other co-speakers, Dr. Balbir, Dr. Hiramat, Dr. Kasturi. It's a great pleasure to join you all on this Sunday noon for this wonderful session on Hyderabad Live. I thank Dr. Saraj Chandra for the invitation. Let me share the screen. Dear participants and panelists and respected chair, basically I'm going to give a talk on OCT as an illustrative case discussion in in-stent restenosis. We all know Dr. Mehran has classified ISR angiographically into 4 patterns. The pattern is focal, which focal has 4 types, A, B, C, and D. A is the focal stenosis at the articulation gap, B is at one of the margins, and C is in the body, and D is on either on both margins. Then comes angiographic pattern 2, which you call it as diffuse, but the growth is within the stent, and pattern 3 is diffuse, we call it as proliferative, because the growth has extended well beyond the stent on either ends. And pattern 4, we call it as totally occluded due to the ISR growth. And OCT in this perspective, we all know the basic pathology, intriguing pathology which causes stenosis in ISR will be the neointimal hyperplasia. But unless intravascular ultrasound, where you call it as in every case as an IH, here it can go a little deeper, meaning by tissue characterization, we call these ingrowths as certain patterns going by name homogeneous, heterogeneous, and neoatherosclerotic. Unlike de novo lesions, the volume of a growth which encroaches the lumen, angiographically, even if it looks less than 50%, one could take a help of FFR to make sure that you are intervening early in a very ischemia-prone growth. And you need not intervene if it is not causing ischemia, because we all know the recurrence rate is pretty high once you keep on touching these ingrowths. Homogeneous is a one. The optical property will be uniform. It will be bright in signal. There will be a less backscattering. Let me take you through a case. This is a 48-year-old female presented as an acute coronary syndrome. It was angiographic pattern 4 by Mehran. And this was basically the index stent was first generation sirolimus eluting stent. You can appreciate the stent is totally occluded. And after the pre-OCT preparation, as upfront as it was ISR, we thought we'll do the cutting balloon, which was taken to 1:1 ratio. You can appreciate in the still image between 3 o'clock to 7 o'clock, there is a still you are able to appreciate a homogeneous growth, whereas in other areas it's been well prepared. And we have taken a stent now after the preparation. After the preparation, the very first OCT which was done after the preparation, which was made it sure that cuts were made. The reduction in the growth was almost 25%. That was the point of a time we have taken the stent. And of course, this time the stent was extending all the way from the left main, crossing the stent across the earlier stent, and we need to do the part side branch opening case. And this is the final OCT following the stent. You can see the stent is extending. There is a overlap with at the distal end. You can see the stent is extending proximally. It is well opposed. You can see a silver scale. You can also appreciate in the still image, the two struts are almost touching each other. There is no great growth in between the two stents. And this is finally looking angiogram in view of diminutive size LCX and good looking angiogram. We thought we not do anything for the circumflex. And We will move on to a next pattern, which is called as a heterogeneous, which has three another different subsets in them, like layered, patchy, and speckled. I can take you through a case. This was the index PCA was done with the Nobori dash down period of 1 year with the late ISR. Again, it was totally occluded. And pre-OCT run showed, of course, in ISR always we do good preparation and do an ISR. It not only confirms the tissue diagnosis, it also tells you what pattern you are dealing with. Unlike the previous pattern, you can see the optical property here is not uniform. There are areas of optical lucency. And we can now delineate how the cutting balloon has impacted. You can see there is a reduction in growth compared to the previous image, and there is a nice dissection plan extending all the way into the previous stent. The basic idea of preparing in ISR with whatever the option you take, whether it is cutting or scoring or laser, we need to know before taking the stent how much preparation you have done, how much you have reduced the volume of the growth to make your stent further extending to prevent the recurrence. So we have nicely demonstrated the impact of cutting balloon. It has, the cut plane is well deep and it is touching the earlier stent. Otherwise, you're going to put the stent just over the growth. You are going to further reduce the lumen area, and you are a good recipe for the recurrence. And after making it sure with an OCT, the preparation is having good. We have taken a stent, and the post stent in need to optimize. We have picked up in an area of under expansion in a longitudinal scale around 20. We have picked up approximately an area of malopposition, for which we have done an additional post dilatation as per the sizes insights we got from the OCT. And this people bring it in heterogeneous, or people take it as a separate entity called as a layered pattern. I am lucky to have in one of my live case this pattern. I was till that time I was reading it in only books. It was again type 3 diffuse proliferative, extending well outside the stent. Happened over a first generation sirolimus stent. You can clearly see in a still picture there is a homogeneous optical character closer to the probe, whereas just after that you can see a uniform optical lucent structure. So this is not homogeneous, this is not heterogeneous. That's why they call it as, there is some uniformity. Within the uniformity there is a heterogeneity, so they call it as a layered ISR. This is typically happens in an ISR which is presenting as an acute coronary syndrome. Again, we do a preparation with a scoring balloon because we thought, because if it's a homogeneous, we take it as a cutting balloon, because in homogeneous it is like a thick fibrous block, whereas in a layered, it is away from the probe, there is a loose material. So we thought, already patient also presenting with an ACIS kind of a picture. So we thought, being in a softer tissue, we will do a gentle preparation. That doesn't mean, softer doesn't mean the gentleness is in how you touch the balloon, but ultimately the volume of the growth, whether it is homogeneous or heterogeneous, the volume of the neointimal hyperplasia occupying, encroaching the lumen has to be reduced by any means, whether it is cutting balloon in case of homogeneous or a scoring balloon in case of a layered ISR. Before putting the stent, the growth should be adequately taken care. The point is you have to reach to the earlier stent when you put the subsequent stent. And of course, the stent was landing from the ostium, and we could again pick up areas of under expansion and malopposition. We could able to see now in between the two stents where there is a very little layer of growth. This is how. So between the second stent and the earlier stent, after the preparation with the demonstration of OCT, making sure there is a good amount of reduction of the growth. Now your second stent should go and sit over without any in between neointimal hyperplasia, whatever pattern you are discussing. After addressing those, after picking up those areas of underexpansion and malopposition, we could able to do it with an additional post dilatation. We are able to correct it, and you can, if you look at it here, with the distal reference, we got, which is a 5.58, we got somewhere around 5, which if you apply the Illumin 3 criteria, it is a more than 90% expansion, and malopposition was also similarly addressed. And finally, it came out as a good opposed stent with a good luminal area. And the second stent is almost touching the first stent with no growth in between. This is the final check angiogram in a patient who presented for first generation DES in an acute coronary syndrome pattern with a typical layered ISR. I was lucky to have that pattern. And this is another pattern which we call this neo-atherosclerotic ISR. In any kind of an ISR which starts as an heterogeneous ISR or a homogeneous ISR, as time dwells, there is a tendency to convert as a neo-atherosclerotic ISR. The moment you demonstrate it is a neo-atherosclerotic ISR, it's a case asking for another stent. So here they have picked up a microvessel, they have picked up spotty calcium, they have picked up lipid, they have picked up peristent low density area, they have picked up, sorry, this is calcium, spotty calcium. I think this is thin cap fibroathyroma. I think this is a macrophage. So they have demonstrated macrophage, they have demonstrated thin cap fibroathyroma in ISR. They have demonstrated a lipid, they have demonstrated a microvessel, they have demonstrated a peristent low intensity area. So I call it as atherosclerotic, neo-atherosclerotic ISR. And this is again a Mehran type 3, a diffuse ISR extending, diffuse proliferative ISR extending well beyond the stent. And you can appreciate after the preparation, we are making sure this panel is telling you sizing of the stent, and this is telling you how much the preparation balloon has given you the dissection, and this is telling you the clear pattern which started as a homogeneous but subsequently got converted into a neo-atherosclerotic pattern. You can appreciate in the panel again the amount of dissection it has done, which I said earlier. There's a foamy macrophages, calcium, thrombus, and microvessels. Basically, it is a homogeneous ISR which got converted over a period of time as a neo-atherosclerotic ISR, and subsequently we had to put the two stents overlap, and we are diagnosed in a proximal malopposition which was taken care. And this is a final expansion. We got somewhere around 5 for the distal reference of 6.5. I think the residual stenosis. I think you must have dilated one more post dilatation after that. OCT run would have been done again, I think. And so what are the options we have now? We have a plain optimal balloon dilatation. This is basically in an underexpansive ISR. Underexpansive ISR is an ISR where it is an undersized or underexpanded stent. The residual stenosis, which has now become a recurrence, where we need to fix most of the time with balloon-based therapy. But the proliferative ISR is ISR, which is a true ISR, which is the most challenging ISR. If the preparations are not done properly, and if you prematurely deploy the stent, like in calcium, this can also give recurrence, stent thrombosis, and whatnot. So we need to know when to use cutting balloon, when to use scoring balloon, and in a cases where, particularly in a case like a layered heterogeneous ISR, that too, which is getting limited to the stent within in a focal or a diffuse pattern within the stent, one with a good preparation, if the dissection is not extending beyond the earlier stent, one can get away with the drug-eluting balloon also. Of course, there is an option of stent. There is an option for stent always there. There is a little papers between the DEB versus with the everolimus eluting stent based on ISAR desire trial and RIPS trial and PEPCAD and various DEB trials. There is a little edge for the second generation everolimus eluting drug-eluting stent over drug-eluting balloon in a diffuse and proliferative ISR. However, there is always a case for drug-eluting balloon in a recurrent multi-layered ISR. And there is a concept now coming up with a laser atherectomy. Once particularly in a multi-layered recurrent ISR, go with the laser atherectomy technology, make sure there is a good reduction in the volume of the growth, and you can get away with the regulating balloon instead of putting another stent to avoid stent thrombus. So, dear panelists and moderator, to conclude, OCT is a very useful tool to diagnose a proliferative ISR, which is a true ISR, and various patterns gives histopathological insights that happens in neointermediate hyperplasia. It also depends on the desk type, polymer strut thickness, and drug coated in the polymer. Homogeneous ISR and neoatherosclerotic ISR, which I showed in one of my cases, almost warrants a second stent. Of course, in my case, it was a very diffuse, totally occluded. And in a heterogeneous ISR, like I said, in a layered pattern, where the optical properties are little softer, and when you can do it with, when it presents in a focally, you can get away with the regulating balloon too. And in ISR, always you can take a help of FFR, not to miss an ischemia pro lesion, at the same time, not to prematurely touch a non-ischemic growth, because growths need to be touched when they are really causing ischemia, they are really encroaching the lumen. Thank you, one and all.
Thank you very much.